Excellent. Well, welcome everybody to this fantastic session this afternoon. So this afternoon's session we are going to be looking at is educational developments, curriculum and techniques in health, which is a really exciting topic and one that I'm very passionate about. And I have some fantastic presenters who are also very passionate around this area as well, which is amazing. So I am Kelly Squires. I'm going to be your chair for this afternoon's session. So I am a dietitian by background. I'm also currently doing my PhD in the area of simulation within dietetic student placements. So this is definitely the right session for me this afternoon, and I'm sure I'm going to get a lot of things out of our presenters as well. So firstly, I just would like to begin by acknowledging the traditional custodians of the lands on which we are all meeting today. I'm presenting from the traditional lands of the Kamilaroi people, which is in Tamworth, regional New South Wales. So just would like to pay our respects to elders past and present and extend that respect to Aboriginal and Torres Strait Islander people who are here today. So as I said, we do have a very exciting session for you this afternoon. Our first presenter is Kat Blake. So I will get her to turn her video on. Kat is a very busy woman this afternoon. She is going to be jumping into another session. So we'll see how we go with time. And because she is jumping ship, we might see if anybody's got any questions for her before she leaves. But Kat is going to be talking about what keeps you up at night, simulation approach to maternity emergencies in rural New South Wales. So I'll hand it over to you, Kat. Thank you.
Awesome. Thank you very much, Kelly. I'll just bring up the screen. Fantastic. So as with Kelly, I'd like to also acknowledge the traditional owners of the lands in which we meet today and pay my respects to the elders past, present and emerging. I'm coming to you today from Ngunnawal country in southern New South Wales, and I'd also like to acknowledge any members of the Aboriginal and Torres Strait Islander communities who are participating with us here today. So today I'd like to start with a little bit about who am I? So my name is Kat Blake, as Kelly said, and together with Todd Adams, we are the Rural Innovation and Learnings team at HETI, which is the Health Education and Training Institute for New South Wales Health. And as part of our role, we support simulation-based education and training to clinicians working in rural and remote New South Wales facilities. And we work with local health districts and specialty health networks to identify and address the learning needs that are present there. This afternoon, I'm going to be talking to you about one of the programs that we developed to prepare clinicians for maternity emergencies in rural New South Wales, our Rural Maternity Care course. So we titled this presentation, What Keeps You Up at Night? And I want you to imagine this. If you're a doctor or you're a nurse or a paramedic working in a small country town in a rural location, the next closest hospital to you is 300 kilometres away. It's you and a team of maybe 2 other people who have some local paramedics, and that's it. So what is it that keeps you up at night? What is that patient that's going to turn up at 3 o'clock in the morning that stresses you out, that makes you anxious? And that was the question that we posed to nurses, paramedics and doctors who are already working in that location. And the feedback was consistent for everybody that we asked. It was pregnant women and women in labour. Pregnancy and unexpected birth cause a significant amount of anxiety, and the people that we were speaking to did not feel adequately prepared to manage this situation. So it was at that point that we decided to see what it is that we could do to help. So in the development of the Rural Maternity Care course, we needed to take a moment to understand the background of where it is that this anxiety is coming from. The research and the evidence tells us that women requiring maternity care, sorry, I'm just, some of these slides are not going forward. Okay, sorry about that. So research and evidence tells us that women requiring maternity care require clinicians with specialist skills and knowledge to care for them safely and effectively. However, for people who may have the knowledge but aren't able to practice those skills, they lose their confidence in that skill over time. Delivery of healthcare services in rural areas of Australia are complex and challenging, primarily associated with issues such as geographic spread, low population density, recruitment and retention difficulties, as well as the high cost of service delivery. And so all of these factors have resulted in this gradual closure and centralisation of maternity and birthing services across the rural locations. And with that, we have lost those skilled clinicians who practice in that area, leaving this lack of experience and skill and practice in those rural areas. With the increasing distances between birthing services that happens, women are now having to travel up to several hours to access their nearest birthing facilities. And as a result, each year there is a significant number of women who present to their local hospitals that are non-birthing facilities in either established labour or in need of maternity care. The map that you can see on screen here, and those pale purple stars, is an indication of where non-birthing services are located across Australia. And you can see through the spread of that most of those are located in those rural and remote locations, with 68% of healthcare facilities in those areas not providing maternity or birthing services. However, several of these non-birthing services actually have more births per year than some designating birthing facilities, with 8% of services having over 100 births a year. So you can see the clinician's anxiety about caring for a pregnant woman or a woman in labour is actually very justifiable and understandable because it is their experience. So what did we decide that we needed to do about this? So our research that we undertook of participants from some of our existing programs highlighted this need for us to develop a resource that would bridge the knowledge gap that was existing. And we convened a subject matter expert group to help to explore the issue deeper and to address the issue. So we convened a subject matter expert group of interprofessional clinicians. So we had both people who were skilled in maternity care, so we had obstetric and midwifery colleagues come and join us, but we also had members of our target learner group, so rural and remote nursing, medical and paramedic team members who could all contribute to actually developing our learning resources. Through our investigations, we found some really interesting things. So we found that there were some resources, but very few that specifically talked about this field that we're interested in. There were very, very few guidelines that were specific to nurses, and even fewer for doctors. For the paramedics, the existing at this point in time policies and practices that they had were very small. Diesel seemed to be the fix for most things. Most of the guidelines and policies were very specific to maternity and birthing services, and they can't be extrapolated out to those non-birthing facilities. So as a result, we found that there was actually a really wide variance in practice, and that practice was very ad hoc, very fly by the seat of your pants approach, trying to remember what I learnt in med school or when I was a reg or maybe from uni, and our clinicians felt lost and scared. So we actually developed the Rural Maternity Care course and launched it in 2017. We launched it to a homogenous group of New South Wales ambulance paramedics, specifically because we wanted to ensure that we met their really unique learning needs, given their very specific environment that they work in, before we distributed it to the wider interprofessional group. So what is the Rural Maternity Care course? So it's a 2-day interprofessional program designed to assist clinicians improve their confidence in the management of pregnant and birthing women and their newborns. The program provides our learners with some foundational knowledge and really simple management strategies, but we also encourage that critical thinking and shared decision making. The interprofessionality is a really core part of the program because we strongly believe that those who work together should train together, and the reality of our rural environments is this is how it's going to look. In the development of the program, we incorporated some behavioural insight principles, which considered things like demystifying the language around pregnancy and birth and taking away some of that confusion and mystery around how a woman actually gives birth for those non-maternity trained staff. We took a real back to basics approach to anatomy and physiology of the pregnant and birthing woman, and really tried to actually break it down into a structure that was familiar to them, but also applicable and relevant to the environments that they're working in and how they're going to actually care for these women. We used evidence and guidelines to actually support what we were developing, and referred to the specific scopes of practice of each 3 professional groups, which took a lot of time to explore what each scope of practice is and ensure that we were meeting everyone's scope and addressing them individually as well as the whole group. And then we used simulation scenarios and skill stations to help actually foster learner confidence throughout the whole program. All of our learners participated in discussion and simulation activities, and they got to practice the skills after each of those sessions, but within their scope of practice. What we allowed them all to do was also develop that mutual understanding of each other's scope of practice, so that they could allow each other to work together when they actually come to that reality of the situation at work. So that shared understanding, social connection that we started to develop allowed people to start problem solving and developing those management strategies together. And so also helped to improve that teamwork, communication and problem solving. So we had our curriculum consisted of several sessions, basically falling into that assessment of the pregnant woman and about care of the woman in labour, complications in pregnancy, so talking to things like cord prolapse in particular, complications in birth, so things like shoulder dystocia and breech birth, postpartum complications, and then we had some sessions focusing on the care of the newborn and the adaptations of the newborn, and then resuscitation. And so we had skill stations scattered throughout the entire 2 days that allowed the learners to actually practically apply these skills after consulting each of the theory components. So our results and feedback has been amazing. Everyone loves it. It's fantastic. So since its inception, we've actually delivered 7 real maternity care courses. We are a team of 2, so we don't have a lot that we get to deliver, but we try and deliver them as much as we can. We've had almost 90 learners attend. They've all been interprofessional group, nurses and paramedics being the predominant group, which is reflective of our learner audience. But we've also had several medical colleagues as well. Sorry, my slides for some reason don't want to progress forward. During each of the commencement of the program, we had all our learners complete a Likert scale slide, Likert scale evaluation, and they got to actually add some commentary to each of that. So most of our learners all reported they had this increased confidence and awareness about providing care to a pregnant woman. They really appreciated the clarity that we provided them around their scope of practice and making people understand where they can do and what they can do in that space. We had an active inclusion of the interprofessional audience, and that was really, really appreciated as a really important part of the program, being able to understand what each other can do and how together they can all get through what is becoming a stressful environment for them, and allowed the improvement of that team dynamic and that teamwork as an important component. As much as I love the numbers on a page that tell us everything's wonderful, it's the words of our learners that are really valuable and important to me. And it's that really powerful feedback that can come from our learner, often days, weeks or months down the line, when they've actually had often an opportunity to practice some of these skills. I will give you fair warning, if we do come and deliver this program on your site, you will have a baby after we leave. It seems to just be the way that things happen. But all of our learners have reported afterwards, when they have encountered these, that they feel so much more confident when they're facing the situation and have a much better understanding about what it is that they're supposed to do, and they feel safe and they feel like they're given good care. And that's the thing that we really like as a takeaway message for our learners. So since its inception in 2017, a lot of things have happened. We'll consider the plague or COVID as one of them. There have been also some significant changes in how the support systems are structured for our learners. So the removal of the perinatal advice line, which was a service that was provided. New South Wales Ambulance has also updated the scope of practice for their paramedics and implemented a whole series of new guidelines. So we've updated and changed our content to reflect this. We've using other sort of different approaches to help support this and development of some other modules to help support what we're doing with our learners out in the broader community. We unfortunately haven't had a lot of policy changes to our guideline updates for our nursing or medical specific groups, but hopefully that'll be coming in the future. From here, where are we going? Keep doing more of these. Everyone seems to want us. There's definitely a need and a thirst for it within our community. We have recently developed and launched some e-learning modules that will help support our learners remotely, and we will continue to look at developing more of those so they've got also some learning they can do when they need to do it and some just-in-time learning on site. So that is about it. Some references. That is it. Thank you all for your time, and I will hopefully, if there are any questions, get to them later.
So Kat does have to jump out and jump into another session, so unfortunately won't be here for the Q&A. So if anybody did have any quick questions, feel free to put them up on the Wova app. Kat, that was great. It was so good to see, and the fact that it's so flexible and you've got the training, but then looking to move into that e-learning, and particularly those statistics around all those rural areas. It's amazing. So you can really see how this would be such a valuable program for them to be involved in, and just interprofessional as well, how you've integrated that. So
thank you very much.
It looks like nobody's put any questions up. So Hook, you can run into
Thank
the other
you,
session and start presenting in that one. Thank you.
Cheers.
Fantastic. All right, well, we are going to keep moving, and we have our next presenter, which is Namrata, who is going to be talking about interprofessional midwifery and medical student simulation-based education in COVID. How does the online format impact learning? So another exciting topic that I can't wait to hear. So I'll hand it over to you, Namrata.
Thank you. Thanks so much. Just let me know that you can see my screen.
Yes, all good.
Perfect. So as Kelly so kindly introduced me, my name is Namrata. I'm a doctor at the Alfred Hospital, and I'm also affiliated with Monash University here in Victoria through my research publications and having completed my medical education there. So as a nice follow-on from Kat's presentation, I too will be speaking about a midwifery and medical student-based educational initiative, which is a simulation-based program involving both professions that has been transitioned from an in-person format through to an online format in the face of the COVID-19 pandemic. I would like to thank my co-authors, Dr. Fernando, Miss Suzanne Wiley, Miss Kim Davey, Miss Jennifer Hocking, Dr. Malhotra, and Dr. Arunaz Kumar for all their help in the development and implementation of this program. So in terms of what the rationale is behind this study and this initiative, as we all know here, simulation is a fantastic way of teaching those hands-on skills to students and learners. It leads to longer-term retention of that learning because of that muscle memory and that physical action of doing a task or completing a skill. I think this is especially pertinent in a healthcare setting where, while the theory is exceptionally important, application of that theory in a real world scenario, especially in such a high risk scenario where people's lives may be at play, is so important. And I think simulation is a wonderful way of achieving and implementing that. This particular study was based on a initiative known as the Obstetric and Neonatal Emergency Simulation Workshop. This is a long-standing workshop that's been running for the past 6 years across a number of countries and has seen 3,000 healthcare students come through it. And it's aimed at engaging medical and midwifery students to improve their comfort with and their management of obstetric and neonatal emergencies in an interprofessional setting. In terms of why our study has come about now, in the face of the COVID pandemic, while it's placed a lot of challenges in a number of areas, and especially in terms of learning, it's also presented an opportunity to explore how an online version of a simulation-based workshop may play out and what students' experiences and what the learning they're able to gain from that workshop is. And as we can see from this graph here, over half of all learning has been converted from a face-to-face setting to an online setting. And I think in the face of this pandemic and potential future pandemics, we're going to need to be a bit more prepared and know how to cope with these challenges. So I'll run you through the structure of our online workshop. So first of all, we had a pre-brief for our students where the structure of the workshop was outlined to them and they were told to take notice of the communication between the healthcare practitioners in the simulation. Second, we had the simulated clinical scenarios that were being live streamed to the students via Zoom. And this was involving both obstetricians and midwives. We simulated neonatal resuscitation, postpartum hemorrhage, and shoulder dystocia. And then within that same Zoom conference, there was breakout rooms, including either a obstetrician or a midwife in each smaller group and a mix of medical and midwifery students who then decided to discuss what they had seen within the scenarios and areas that they feel could have been improved between the communication and management of that scenario and a general discussion of their thoughts and opinions. So here I've got a short clip, which I will play that shows our OneSim simulation in action.
So we're doing this for the last 30 seconds. So what is the heartbeat now?
Maybe heart rate is more than 70.
Okay, so we'll stop chest compression. So we'll still keep going with the positive pressure ventilation until we establish a spontaneous breathing or it's fine. Okay.
So here we have a pediatrician who is leading the simulated neonatal resuscitation with 2 of our students who are participating in the simulation. And here we have a picture of our students observing the simulation via Zoom, and we have our simulation being broadcast to the students and our facilitators also observing the simulation. In terms of the aims of our initiative, we wanted to find out, first of all, how does an online OneSim workshop actually impact student learning? Secondly, what are students' perceptions of obstetric and neonatal emergencies when observed through an online simulation? And thirdly, how do medical and midwifery students perceive the interprofessional aspects of management of these emergencies when they're delivered online? In terms of potential participants in the study, a total of 199 students, 149 of which were medical and 50 of which were midwifery, attended the workshops and were invited to complete a post-workshop survey. In terms of the actual survey itself, the survey consisted of 3 text questions that were aiming to evaluate, firstly, how and what students learned from the online approach to one sim. Secondly, how the online format impacted interprofessional interactions. And thirdly, how online learning will actually influence their approach to future practice. Amongst those who attended the workshop, there was a 30% response rate to the survey. And amongst those who completed the survey, 70% of them were medical students and 30% of them were midwifery students, roughly emulating the breakdown of medical students and midwifery students included in the workshop itself. In terms of how we derived meaning from our data, we collected out these survey responses, and these survey responses were then separated by profession into medical survey responses and midwifery responses. And a thematic analysis was then performed, which meant that we assessed each survey response, assigned some key words that captured what was being said, and then divided these and summarized these into the following 6 themes, which I'll now go through. So the first predominant theme was adaptability, and that was relating to students' ability to cope with a lack of in-person teaching and adapting to a new way of teaching through e-learning, which is a method of teaching that they're in fact less comfortable with. The second refers to connectivism, which is the concept that digital technologies such as the video conferencing platform that we used in our study provides a new avenue of learning, and that learning itself is influenced both by social interaction, aka the interactions between medical and midwifery students and between themselves and the facilitators, as well as technology. Thirdly, there's preparedness for practice, which is revolving around the simulation's ability to increase students' confidence when approaching similar scenarios in their work-based placement, as well as when they're independent practitioners. We then have experiential learning, which is referring to that real-time, hands-on aspect of the simulation and the realism that can be created through the simulation. Fifth, we have learning through modeling, which is capturing that experience of students observing healthcare professionals, either midwives, neonatologists, or obstetricians, that partaking in the simulation, and in a way creating a best practice model of such a situation. And finally, we have dynamics of online interaction, which is representing that interplay between medical students and midwifery students and how the online setting impacted their perceptions of one another. So in terms of the outcomes of our analysis, we found that there were 2 major themes amongst medical student responses. The first theme was experiential learning, which, as I mentioned before, relates to that realism that can be created through simulation. And the second is learning through modeling. So that observation of role models, in a sense, of expert practitioners partaking in the simulation. And I think these quotes really speak for themselves. It shows that even in an online setting, that simulation was able to invoke that intense emotion that occurs in an emergency and therefore can give that real-time experience to the learner. Amongst midwifery students, the major theme was the dynamics of online interaction. And once again, we've included a couple of quotes here, but I think that second quote really goes to show how powerful this online simulation was, in the sense that it had that ability to break down the hierarchy that does exist between midwives and doctors and makes it a more level playing field, even in this online setting. In terms of what these findings actually mean, they're very much in keeping with previous studies that have been based on in-person workshops, which demonstrates that the online format did not actually change key learning outcomes between both disciplines. And by extension, that demonstrates that these online simulation programs do play an important role in student learning, and they do have the ability to influence interprofessional attitudes at an early grassroots level. In terms of where our research sits in the rest of the literature, since the COVID-19 pandemic, there has been a growing number of studies that evaluates either simulation-based education or interprofessional education in an online setting. However, there tends to be a scarcity of literature that evaluates online programs that combine both simulation-based education and interprofessional education, particularly in a maternity setting, which our study is aiming to address. And although our study may be unique in the sense that it's covering a certain area of the literature, just like many other studies in this field, it shows that online simulation-based education and interprofessional education is able to achieve many of the same learning objectives as traditional in-person initiatives. And I think that's something that's extremely valuable to know and will carry on well beyond this pandemic. That comes to the conclusion of my talk. Thank you all very much for listening, and thank you to everyone involved.
Thank you, Namrata. That was a great presentation, and it's just, I'm loving seeing all this interprofessional simulation that is occurring. And I think it was the first midwifery quote that you put up, and just the term mutual respect. It's just so nice that those attitudes and those findings of being, are evolving as well as everything else that we put into the sims.
Definitely.
Yeah, great. All right, well, if you do have a question based on that presentation, please use the platform and we will have a Q&A at the end of these sessions. But right now we are going to keep moving, and the next presenter we have is Nathan, who is going to be talking about Taming the B.E.A.S.T. That sounds very interesting, so I'll hand it to you, Nathan, so you can tell us all about it.
Thanks, Kelly. Hi, everybody. I'm Nathan Sharrock. I'm a clinical nurse educator at Belmont Hospital, which is located on the Butterbar lands of the Awabakal people, and this is Taming the B.E.A.S.T. So, as we all know, simulation is a well-recognised education strategy to support development of critical thinking skills in recognition and management of the deteriorating patient. In situ training has been shown to improve communication and teamwork within the multidisciplinary team. The Belmont Emergency Acute Simulation Training, or B.E.A.S.T. program, was first established a couple of years ago as a very basic in situ simulation program aimed at the nursing and medical staff of Belmont Hospital Emergency Department. Since then, it has evolved into a high-fidelity multidisciplinary program that we now have. What sets B.E.A.S.T. apart from other ED-based simulation programs is that we have expanded our multidisciplinary approach to include the New South Wales Ambulance Service, with each simulation scenario now beginning with a pre-hospital phase. B.E.A.S.T. utilises a preventative rather than a reactive model to promote safe patient care in a protected, supportive and familiar environment with staff working together in their own team. Belmont Hospital, just as a bit of background, is a smaller district hospital in the Greater Newcastle area. Our services include Gen Med, Gen Surge, rehab and residential aged care, as well as a CCU/HDU. Our ED has 12 funded beds, including 2 resus bays. It sees approximately 30,000 presentations a year and averages about 6 Category 1 resuscitations per month. The B.E.A.S.T. simulation scenarios are based on specific populations that present to Belmont Hospital. Familiar equipment is used to promote better utilisation of our equipment, with a focus on better resource management. B.E.A.S.T is run once a month, with each session running for 1 hour and repeated 4 times throughout the day on topics relevant to emergency. Each session includes pre-brief, the simulation scenario and debrief, plus or minus education depending on the specific topic of the simulation. The sessions are facilitated by an emergency physician and nursing team, and nursing education team, and includes participants from medical, nursing and paramedics. While there is a general plan for each scenario, they are very much a choose your own adventure, meaning that the progress and outcome of each scenario is very dependent on the course of action taken by the participants. The involvement of Ambulance Service New South Wales allows each simulation to commence in the field and include transport, handover and transfer of care as part of the simulation. Paramedics initiate early treatment but rarely get to see the full benefit and impact of that pre-hospital care has in relation to the patient outcome. With this training, paramedics get the opportunity to participate and observe how the combined scope of practice of paramedics, nurses and doctors and the skills they all bring contribute to the patient's experience. The paramedic participants are given an outline similar to what they would receive when responding to cases. They carry all the gear and address the patient and bystanders as they would when arriving on scene. They then need to assess, treat, call for backup if required, and send through a code to the hospital, load the patient and present them to ED. We try to make the scenarios as authentic as possible. When paramedics present patients to emergency department, there is never time to explore changes that would potentially result in smoother transfer of care. Quite often there is details not relayed or that haven't been heard in the rush to initiate definitive care. By doing this training together, we are able to take time during debrief to discuss any potential improvements that we can make to our processes and then retry to see if there are any actual benefits. The main thing that has come out of this type of training is that all involved have more respect for each other and the importance of their individual role, which in turn leads to improved teamwork, resulting in better outcomes for the patient. One of the biggest advantages of having Ambulance New South Wales involvement in the B.E.A.S.T program is that we have been able to identify potential risks and complications which may occur during the handover and transfer of care process. This has allowed us to facilitate changes in our practice. One of the best examples of this is during a cardiac arrest. As ED clinicians, our natural instinct is to jump right in and take control of the situation. But by doing so too early, we increase the chance of confusion and potential errors occurring, especially in relation to CPR and defib cycles and drug administration. What we found was that by allowing Ambulance Service New South Wales to maintain control of the situation, including finishing whatever cycle they were currently on, before transferring the patient from ambulance stretcher to ED bed, and thus transferring control from Ambulance New South Wales to ED, we were able to greatly reduce these potential risks. Belmont Emergency Department, like most other EDs, has a huge range of experience among both nursing and medical staff. We have a very junior new graduate nurses rotating through the department as part of our new grad program, right up to registered nurses and CNSs with more than 20 years of ED experience. Similarly, our medical officers range from staff specialists to JMOs and everything in between. The B.E.A.S.T program has given our junior staff the opportunity to work alongside the seniors and to gain exposure and experience in a controlled and supported environment. It has also allowed our senior staff to witness the varied knowledge and scope of practice within the department and to realise that while everyone may have advanced life support accreditation, there is a vast difference between the ability and confidence of a second-year RN with ALS versus an RN with 10+ years of experience. While the goal has always been to run the B.E.A.S.T program in situ within the emergency department, in reality, this is not always possible. Factors such as department activity and bed availability can influence this. To counter this, the boys from the Belmont Hospital workshop have put their creative skills to use and built us our very own mobile resus bay, with all the attachments and outlets to resemble one of our ED resus bays. Using our mobile resus bay combined with our iSIM means we are able to relocate B.E.A.S.T to our education rooms should the need arise. Our education room also has access to the outside world as well, meaning that it is an ideal secondary space to run B.E.A.S.T while ensuring Ambulance Service New South Wales still has access to the room. The Belmont Hospital Education team are also very good at collecting expired stock, and this is particularly useful in avoiding excessive wastage of resources when running the B.E.A.S.T program. We also have a good relationship with our pharmacists who keep any expired drugs for us to use, again, to avoid wastage. We have used both mannequins as well as live actors for the patient in our scenarios, depending on the needs and the projected outcome for the individual scenario. While the participants certainly gain more from having a live actor, and this is reflected in the feedback, none of our actors would appreciate being intubated or having CPR performed on them. Most of the education team has had at least one opportunity to get dressed up and put on some makeup and test our acting skills. Fortunately, for those times when we are unable to use a live actor, we have had access to a high fidelity mannequin, which allows us to make adjustments on the fly and provide real-time feedback. Aside from practicing and improving the handover and transfer of care process, the other benefit of having Ambulance New South Wales involved in B.E.A.S.T is to see how the other half lives. In order to achieve this, we set up a live feed to our tutorial room using an iPhone with microphone attachment and a connection to the tutorial room computer and overhead projector via Skype. While the pre-hospital phase was being performed, the hospital staff could watch everything via the video feed before heading out to the department for handover. Once transfer of care was complete, the Ambulance Service New South Wales staff could then retire to the tutorial room where they could continue to watch the live feed. This allowed all participants to be involved in the simulation from start to finish and also avoided having extra bodies crowding the simulation environment. Our debriefs are more informal and held in a safe and relaxed environment and will quite often take place outside in the fresh air as opposed to inside a tutorial room. Having both ED and Ambulance New South Wales staff in the debrief has allowed for some very open and interesting discussion. It has given staff the opportunity to ask questions around different treatment pathways and their impact on the patient. It has given ED and Ambulance New South Wales staff the opportunity to allow them to learn why each discipline does what they do and explore these options. What is evident is that both paramedics and ED staff now have a better understanding of the importance of their individual care and treatment of patients. When we use a live actor as a patient, they are always included in the debrief. Being a patient, even in a simulated situation, can be very confronting. And we find it very interesting and beneficial to get the perspective of how the person who was performing the role of the patient felt and their experiences throughout the scenario. At the completion of debrief, we provide participants with a short feedback survey, and we have used the information gathered here to guide and develop the B.E.A.S.T program to better suit the needs of our staff. The B.E.A.S.T program has allowed us the opportunity to improve patient safety through better understanding and practice resource management, as well as improvements in teamwork and communication. Staff have also shown improvements in self-confidence and their ability to recognise and respond to a deteriorating patient and manage priorities. B.E.A.S.T helps reduce clinical risk and mitigates the possibility of unexpected outcomes in care delivery. The involvement of Ambulance Service New South Wales has resulted in the identification of potential risks involved in the handover and transfer of care process and facilitated changes in practice. Emergency departments realise their potential when the culture of multidisciplinary care is one of collaboration, working within the scope of understood roles and responsibilities. B.E.A.S.T supports this understanding and increases staff confidence and competence. B.E.A.S.T is more than merely a set of simulation days. It is a driver of culture. B.E.A.S.T provides the platform for excellent care and in doing so lifts the team to operate openly in acknowledgement of each member's contribution and interdependence. We would like to acknowledge and thank Nursing and Midwifery Services Hunter New England for providing us with funds via nurse strategy funding. This funding has allowed us to ensure staff are available to attend B.E.A.S.T while maintaining safe staffing within the emergency department. We would also like to thank the doctors and nurses of Belmont Emergency Department, as well as the paramedics of Ambulance Service New South Wales, for their enthusiasm and willingness to get involved. Without these guys, there would be no B.E.A.S.T. I would personally like to thank Dr. Hamil Patel for being the driving force behind the B.E.A.S.T program, Janine Bond and Bradley Taylor from Ambulance Service New South Wales for organising the ambulance crews and equipment, and adding the finishing touches to the scenario to ensure they meet the pre-hospital learning needs. And last but not least, I would like to thank the amazing education team at Belmont Hospital, who are some of the most believable actors I've seen and could easily score a role in any medical drama series. Thank you.
Sounds like you need to be handing out some Oscars there. Well done. Thanks, Nathan. I've never worked in the emergency department, but I imagine the chaos and the uncertainty of working in the department, you've captured it really quite nicely with the name B.E.A.S.T. So I think that's probably a very good name for that. And I love the use of technology so that, you know, everybody can experience what the paramedics are experiencing, and then they get to flip it around and then experience what happens after they hand the patients over. So thank you. If anybody's got any questions for Nathan, pop them up onto the platform and we'll get to the Q&A session afterwards. Great. All right, we are heading into our final presentation for this session. We've got Sue, so I'll get Sue to pop her video on and get her presentation all ready. Sue is going to be talking about using interactive 3D animation to improve simulation-based shoulder dystocia and breech birth training. So Sue, I'll hand it over to you. Hopefully you're going to perfect screen share. I'll just get you to unmute and put your video on. Oh, we're going to play. Excellent.
Sue, we can't hear your sound. Do you want to, could you please unshare and then share again? And just before you click OK, you'll need to tick the 2 boxes under at the bottom of your screen. So if you try sharing again, please. And then it should say share sound at the bottom. If you can click that for me, and then, yep, then it should play. No, still no sound.
To improve simulation-based shoulder dystocia and breech birth training. My name is Sue Hampton. I'm actually a midwifery educator at the Clinical Skills Development Service in Brisbane, Queensland. And I also did this project with a couple of my colleagues whose name appear on this front slide. So why did we do this project? Well, the background really was that shoulder dystocia and breech were pre-reading to be done before you can perform these manoeuvres on a mannequin. So prior to coming to the simulation, we expect our learners to actually have done some pre-reading. So we looked at what was out there, and I'm going to just warn you before we go any further with my.
Sue, we seem to have lost your screen. Sorry, everybody. Looks like we're, oh, here we go.
Good afternoon. I'm going to be presenting the using of interactive 3D animation to improve simulation-based shoulder dystocia and breech birth training. My name is Sue Hampton. I'm actually a midwifery educator at the Clinical Skills Development Service in Brisbane, Queensland. And I also did this project with a couple of my colleagues whose name appear on this front slide. So why did we do this project? Well, the background really was that shoulder dystocia and breech requires pre-reading to be done before you can perform these manoeuvres on a mannequin. So prior to coming to the simulation, we expect our learners to actually have done some pre-reading. So we looked at what was out there, and I'm going to just warn you before we go any further with my slides that obviously these are animated pictures, but they are images that are animations of shoulder dystocia and breech birth. So obviously they're quite confronting for some people. So if you don't want to watch any further, this is your opportunity to leave or blank your screen. So current teaching aids are relatively scarce and they are very limited. Teaching aids are sometimes a little bit inaccurate, they have copyright restrictions, and generally most of the teaching aids are two-dimensional. So this always causes and creates lots of issues when you're trying to teach a three-dimensional type of process or technique. So this is a picture of myself and one of my colleagues here actually performing what's called a Rubin's 1 manoeuvre on a mannequin. Learners are required to visualize the actions of the maneuvers, and the interactive 3D animation actually improves their experience of the simulation-based training. So in shoulder dystocia and breech, there are multiple different maneuvers, particularly in shoulder dystocia, there are actually 7 different maneuvers you need to remember. So being able to actually perform those or be able to visualize those before you actually attempt it in simulation actually can aid and improve the learner's outcomes. So what were the real aims of why we did this? I've said already about improving the learner's experience, but it also improves the facilitator's experience. You find that your learner actually comes to your sessions much more prepared, much more able to perform the manoeuvres. So you can spend more time actually having a practice rather than explaining. It improves the clarity of performance as well, so people feel more ready and able to go back to their clinical areas and actually be able to perform these in real life. And it does support self-directed learning. There's nothing worse than being in your own environment with nobody else to ask and you don't understand what's going on, whereas 3-dimensional does help that a lot. And overall, it's going to improve clinical practice, which is what simulation is all about. So how did we start? Well, we started by doing a market scan. We did a training needs analysis, and it revealed that there are limited current teaching aids in simulation-based, particularly shoulder dystocia and breech training, actually out there for people to use. And as I've said before, they're all generally 2-dimensional. We engaged with a multidisciplinary team. We had senior midwife, an obstetrician, a 3D developer, digital advisor, and an evaluation expert in our team. This was a really nice mix of disciplines, so we could actually compare notes, and we came up with our plan. The next part was an iterative, rapid prototyping approach with 3D animation tools, which were built using Unity software. This is obviously not my area of expertise, being a midwife, but the 4 subject matter experts were there to review those. They were also midwives and obstetricians, and they reviewed the 3D animation for us. And then finally, we got feedback from the reviewers, which incorporated the final. We put in all the final versions. So it went through several reviews before we came up with the final product, which particularly with the shoulder dystocia took a lot of changes and a lot of tweaking with 3D, but it is actually a really good product now. This picture here just gives you an example of what 2D looks like. So on the left-hand side, we have a 2D picture of a shoulder dystocia manoeuvre. That's a Rubin's 2 that they're doing there. And on the right-hand side, that's part of the Lovesets manoeuvre for a breech birth. But it's very flat, very 2-dimensional. So you can see why people would have problems actually looking at that. My next picture shows you a learner here looking at our 3D simulation, which is obviously done on a laptop here. If you are going to go to our website, which I'll show at the end of the presentation, you do need to do it on a laptop or an iPad. You can't do the 3D on an iPhone or a smartphone. And you do need to use a very up-to-date browser to be able to use it.
Now we're going to talk about the internal maneuvers. So we'll start with Rubin's 2. This doesn't have to be done in this order. We've just filmed it in this order. Please notice we now have removed the base of the bed. The cushion now is probably standing between the woman's legs, same position of the hands. We're going into Roberts that would have been the position she would already have adopted. We probably tried Rubin's 1, unsuccessful, so we've gone internally to provide Rubin's 2. We will show you this again by rotating around the back so you can see the placement of the fingers internally. So we're just going to rotate that camera so you can see the back. And then we're going to play again. You can see those fingers coming in, placing onto that anterior shoulder, and pressure is applied to the anterior shoulder, push the shoulder towards the feet of the chest, releasing that shoulder, and then coming up with the same mechanism with your normal birth to deliver that baby. No excessive traction should be placed to try and deliver the anterior shoulder with the pelvis as well. And you can see those nerves. Again, that stretch, and you can see the fingers through that fetus placed on the anterior shoulder, coming up, and delivery of the fetus onto the mother's abdomen.
So with our shoulder dystocia,
now we're going to talk about the
Sorry, everybody. So with the animation, we actually don't have a voiceover. We allow people just to play with the animation, and you can do that yourselves. So you can go through several maneuvers going forwards and backwards. It does look a bit strange, as you saw in that demonstration when we put the baby back in, but just for demonstration purposes. So what were the results? All subject matter experts agreed that the 3D animation was a valuable training aid for the learners for both shoulder dystocia and breech. I've since used the training aid, particularly with shoulder dystocia, in a number of courses that I deliver here at CSDS, and I've had really good feedback, both from people who teach and people who are actually learning. So it's a great one for them to be able to go away and look at after the courses. All the experts agreed that the shoulder dystocia animation was clinically accurate. 66% of the experts agreed that the breech birth was clinically accurate. The breech birth was done in a less time frame, and I think we probably do need to revisit that at some point, but it is really excellent, as well as the shoulder dystocia. So following on from what we've done, we decided that we really should test out properly to see if 2D and 3D were comparable and whether there were differences. And so we used a group of student midwives and new graduate midwives, and we've done a research project using both 2D and 3D, as I've said. They didn't have any narration. There was just written text with the 2D and written text with the 3D identically. And yes, we had really good results, and the publication is in preparation at this present time and will be ready for early release in 2022. And certainly it shows that mental rotation and the mental ability using 3D is reduced compared with the 2D when you're actually with your group. So from this project, I'd really like to acknowledge my colleagues. You can see them all there. I won't name them all, that played a big part in this project. I wasn't the only person, but certainly from my perspective as an educator, I have changed the way I train, particularly in shoulder dystocia, from what I've learned from the 3D, and I've learned from the 3D project that we've done, the research project. So I hope that you'll all go away and hopefully use this in the future. Thank you for listening today, and if you've got any questions, I think this will happen after this presentation.
Thank you, Sue. What amazing technology there is these days that is possible. We did have a comment from Siobhan on the chat saying it's a brilliant resource, well done, and thank you on behalf of obstetric educators everywhere. So definitely something that is getting noticed, so well done. We do have time now for some Q&A from any of our panelists. So if our panelists want to show their videos, that would be great. If you do have any questions, feel free to use the WOVA app. There's nothing at the moment. I don't know if any of the panelists have anything further they wanted to add or wanted to say about anything. This is your chance now to have a bit of a chat.
Kelly, it's Sue here. I've just put up the website address for CSDS and a QR code if people want to go in and have a look at our website, because there's other things besides the 3D. But if they want to play with the 3D, that's where they go to have a look at it.
Perfect. Well, it's on the screen now. So the website, or grab your phones and scan the QR code. Go and have a little play of what Sue's just shown us. That's amazing.
And it's free access, so you don't have to sign in. People can just go in and look. All the resources are there for free access, which is really good.
So you mentioned you have to use a laptop, you can't use like a phone.
You can't use a smartphone for the 3D. It doesn't download, so you're best with an iPad or something that can actually, laptop's better. To be honest with you, on a bigger screen it's much better. You can get the resolution better as well. So I would say use a big screen, especially if you're teaching. But certainly all the resources you can use on your iPhone.